What about migraine-specific medication treatment days? That's a mouthful. Somebody define this for me. We're going to be hearing this more as we go forward.
Sure.
You
So
wanna take a
my
run at this?
understanding of that is, and it's definitely a mouthful, I'm on a steep learning curve with these long terms that someone came up with, but my understanding is it's the number of days you take one of two classes of medicine. That would be DHE or triptans, which are acute treatments.
Right.
How'd she do?
She's perfect.
Thank you.
Let's talk about some studies. We've got the chronic study, the fremanezumab study from AHS in 2018. What is the trial design? What are the results and the implications for this, in specific with the reduction in migraine-specific medication treatment days?
I think there's two ways of looking at a clinical trial. Point one would be to get a trial that the FDA likes that makes your endpoint positive. So for example, in many trials, they look at how many days a month you have migraine before and after treatment in the active drug and the placebo, and statisticians tell me that's the most sensitive measure of showing a difference. But from the point of view of a clinician, it's a bunch of baloney. I don't really care if you had, let's say for the sake of argument, you had patients who wound up with no headaches and patients with no change, the average would be halfway in between. What to me is more important is the individual response. What percentage of patients had a greater than 50% improvement? And in most of the studies of all the drugs, it's around 50%.
But 50% is huge.
Correct.
I mean, it's a big number.
Correct.
We've seen drugs approved on 3% effectiveness. Not necessarily in the migraine area, but in lots of areas. 3, 4, 5%, some of the oncolytics. So 50%, these are good drugs and
Correct.
big results.
That is correct.
And we know that there's perhaps 25% of patients will have a more significant.
Right. Of the 50% responders, half of them have a 75% response.
Even bigger.
Yes.
This is great news. The impact on the number of days of use, I think this is sort of bundled into that.
Less headaches, less medication.
Less headaches. And then tell me about, this is almost too easy. I'm going to set this one up. It's a softball coming right at you. The decrease in medication overuse headaches.
Here's what's very important about that statement. Many years ago, one of the gospels in the headache world is, if you do not eliminate medication overuse, the patients won't get better. But we've now shown with both topiramate and with the antibodies, it makes no difference. Patients do just as well whether or not they're overusing medicines. And after they take a preventative, medication overuse decreases.
But, okay, I'm not following that precisely. In other words, if you can get a headache from medication overuse of the wrong drug,
Right.
shouldn't giving the patient a better drug or a right drug decrease that overuse headache? Did I miss this?
It used to be, but let's talk. What they're overusing is an acute medicine. Okay. What we do to stop it is to give them a preventative medicine. And for a long time in the field, there was a debate whether giving a preventative medicine would work if you're still overusing. And a lot of people would say, stop it first and treat later. We now have clear evidence with many drugs that if you put them in a preventative medicine, most people will stop overusing because they don't need it.
Okay, the reason I got confused is that sounded so ridiculously obvious that I was surprised nobody thought of that.
Well, it's been a major debate between the Europeans and the Americans, and I've debated them, and the Americans believe treat first, stop later. The Europeans often believe detox first, medicate later. It's philosophically different.
Speaking as an American, I like our way better.
So do I.
It sounds rational. Now, you've got a little accent here, so you're from the other side of the pond earlier. What makes sense to you?
Well, having been through the detox process over 10 years ago, I can say that as a patient, it is not a pleasant experience. I know from my group and my page that patients are really scared of going through what we know as the detox process. And so the concept that we can actually just go on a preventive that is effective without having to detox first is huge. The ramifications are enormous.
And do these studies, whether it's chronic or fremanezumab data, do they support one side or the other? What do the studies show?
They all show that fremanezumab and the other antibodies work just as well with or without medication overuse.
All right. Now, what are the implications for patients with migraine-specific medication day reductions? What is the implication in terms of it changes how a patient lives?
Right, well, obviously, if you take a patient who's having, let's say, 20 to 25 migraine days or headache days a month, then they really don't have a life, to be quite honest. They're in bed a lot, they are probably unable to work, or they are not working effectively, they don't have a social life, they can't attend their their children's school events, it can affect their marriages, and so much more, and it can increase the severity of the comorbid conditions that they have. So the implications of this are huge. The challenges that we're seeing as patients, and we may be getting to this a little bit later, so forgive me, are just actually taking what is in the clinical trials and putting those into real-world use. And in terms of migraine, that is actually very challenging.
And from a payer's perspective, what's your view on all of this? How does this affect the amount of money you shell out?
Well, from an employer standpoint, someone who's a migraineur has to take some time off work, or they get a migraine at work, and many workplaces have quiet rooms for them, or they have to take time off work under the Family Medical Leave Act. So it could be paid or, in some cases, unpaid time. So it can have significant economic impacts in terms of productivity to employer, but also to the patient, to the employee.
What does it mean in terms of actual out-of-pocket expense to a healthcare plan?
Well, the great hope is that we're going to lower cost of care, right?
We've
lower
done
the
that.
total
We've
cost
done
of
in the
care.
past 2 studies, one a generic study in a database looking at the total cost of care before the introduction of any preventatives, and we clearly showed a 50% reduction in total cost, doctor's visits, ED visits, imaging. And we did the same thing for topiramate a number of years later and showed the same thing. So clearly, if you look at the analysis of total cost of care before or after prevention, it goes down.
Of course, it doesn't necessarily follow that costs go down if the cost of prevention is very high, right? I mean, if I have, let's take a ridiculous example, a medication that costs $1 billion a dose, but it reduces overuse, it reduces headaches by 99%. You're not going to approve that, but it's a great drug.
Well, I think we're looking at what is the overall value, right? And even as payers, we now have ICER frameworks to look at value from different stakeholder perspectives. But certainly if there's compelling data that's showing that you're reducing, we usually like to understand the buckets, right? And how quickly should the outpatient, the pharmacy, the inpatient, how quickly does that change? So the more data, and I would also argue for real world data, because these CGRPs are a fairly new class of drugs, but the more we have around this is the right patient, this is the right approach, and be able to measure the impact with both the polypharmacy side, the wrong drugs, being able to get off opioids, but also measure the impact on ER visits and hospitalizations, because that's a big portion of total cost of
So
care.
there's a real advantage for an appropriately priced
Yes.
preventive drug. Fair enough.